Good morning. I'm Dr. Reg Haight, a spine surgeon here in Atlanta, Georgia. I work at the Atlanta Brain and Spine Care. I'm a classically trained neurosurgeon and then fellowship in orthopedic spine. This is our second series of our case debate series. This is hosted by NuVasive. We'd like to thank our industry sponsor and partner, NuVasive, for their help. Today, you're going to hear something a little bit different than our first case series. We're going to hear a couple of peers discuss, debate, talk about the pros and cons of procedural approaches and the application of technology. Today's is going to be about creating a softer landing in our long fusion constructs. So we like to kick off today's debate. It's really complex spine and distributed loading techniques. Again, it's all about a gradual change in stiffness for a soft landing for long constructs. We have a couple of exemplary young spine guys. The first is Zach Tempel. The next is Dr. Jeff Mullin. Zach is a neurosurgeon at the Mayfield Brain and Spine based in Cincinnati, Ohio. I recently had the opportunity to sit next to Zach at a business dinner at the Joint Spine section in Las Vegas, and he and I talked about his ideas at length. Jeff Mullin is a neurosurgeon. He's at the University of Buffalo Neurosurgery. He's an assistant professor at the State University of New York there in Buffalo. So we'll go ahead and have these two guys start their discussion, their debate. After that, I'll add some personal comments to bring this to a close. So let's go ahead and start with Dr. Tempel. Zach, the floor is yours.
Thanks, Reg, for the introduction, and to the NuVasive folks for hosting this debate today. I think this is an interesting topic. In this day and age, rod stress and demand is not really a universal, not universally the same throughout an entire construct, and the optimal degree of stiffness required for the bulk of the construct where the correction happens is not the same as what's necessary at the top of the construct, which is why we place additional rods across pedicle subtraction osteotomy or bolster our constructs at the points of maximal stress. So in other words, in my opinion, or the way that I kind of look at this problem, is it doesn't make sense to prescribe the same universal rod or stiffness or material to an entire construct and then have it abruptly transition to normal anatomy. So really, the question is, how do we transition from a highly rigid construct to a less rigid construct while minimizing the disruption of normal anatomic structures? What I've started doing in my practice for the vast majority of my deformity operations is combining multiple materials with various degrees of stiffness to kind of transition across the construct and really try to be more accurate with how I prescribe a material based on the location of the construct and the corrective goals. So I'm going to start with a couple of cases here. For example, is a 70-year-old male with Parkinson's who had pseudoarthrosis and failure after a 2 to 5 T-lift done at another hospital. Clearly some significant degenerative changes here. We did a single level lateral interbody fusion at the L1-2 level and extended the fusion up into the lower thoracic spine and also fixed the focal coronal deformity there. And in doing this, we ran a parent rod essentially from T12 down to the pelvis, and then which was, I think, a 5.5 millimeter cobalt rod in this case, and then used separate parent rods up at the top to span T10, 11. These were 5.5 millimeter titanium rods, and then we really bridged that gap in this case with another 5.5 millimeter cobalt rod and side-to-side connectors to sort of link in those two constructs together. And the goal here is to provide a little bit extra give at those top two segments and in hopes that this reduces the stress on the adjacent segments. Also, with a technique like this, there's no laminar work done at the UIV +1, no disruption of the posterior ligamentous complexes there, as sometimes is necessary to do a sublaminar banding technique, for example. And it works out quite nicely. This next case is a 70-year-old woman with adjacent segment degeneration, severe foraminal stenosis above a unilateral construct here, a very focal scoliosis there. Not a terrible deformity, really just needed a little bit of correction, which we were able to achieve with the 15-degree lateral cage and extension of her fusion up to T9. And in this case, rather than use the side-to-side connectors, we used pedicle screws with built-in dual-headed screws, essentially, so we could accommodate an outrigger rod. Similar in concept here, in this case, from T11 down to the pelvis, the parent rod consisted of 5.5 millimeter cobalt, and then a separate 5.5 millimeter titanium rod at the top at T910, and then this was connected with outrigger rods that were also 5.5 millimeter titanium. This third case here, this is more of an idiopathic scoliosis case, adult idiopathic scoliosis case with focal sagittal plane deformity, but well compensated overall. Again, we got all of our real correction with 3 levels of lateral. Didn't need a ton of correction in the sagittal plane. Similar in concept here, finished it off with a T9 to pelvis construct, and again, using multiple materials and connecting those with dual-headed pedicle screws at the top of the construct. This lady also, we did an open SI joint fusion on at the bottom of the construct. You can see that there. But essentially, this is a kind of using tinker toys in a way to make the most out of what we currently have available. But if you go to the next slide, which shows pictures of our intraoperative technique, you can see we have multiple materials available, as I said, ranging from super stiff cobalt chrome 6.0 and 5.5 millimeter to less stiff titanium rods from measuring 5 millimeters to 6 millimeters. This is how I started doing the construct before using the built-in dual-headed screws. I was basically would employ the side-to-side connector system we typically use for outrigger rods and kind of match that to the patient here. So there's some benefits here. This is a little bit lower profile of a way to do this. I found that the current availability of the dual-headed pedicle screws, the mediolateral dimension is relatively high, which really precludes their use in the upper thoracic spine. So really, it's almost impossible to get those screws to fit well in the upper thoracic spine. So in the upper thoracic spine, I still tend to use this technique, but this technique also, you can see, puts a lot more stress on the connecting rod, as there's a much larger gap in between where those connectors sit. The other issue with this construct that I foresee biomechanically is that it essentially relays all the stress to the rod itself, whereas the dual-headed pedicle screw technique actually puts most of that stress on the screws themselves. And that's what you'll see here on this final slide with dual-headed pedicle screws, that beautiful drawing there that I kind of sketched up on my own. And then next to it is what this looks like in real life. So where, again, the dual-headed pedicle screws are placed either at the UIB -1 or UIB -2, depending on how much give you want to provide at the top of the construct. Ideally, you don't want to have that gap with outrigger rod spanning T12L1 if you can avoid it. But again, this is a very nice way, I think, to share that load with the pedicle screws and create a very biomechanically strong construct at the top while providing some give there and preventing undue stress on the superior levels. Again, I have some experience with sublaminar banding. I really like the concept of it, but the question is technique, and Jeff will go over that in much more detail and kind of explain some of that. What I have found in some cases with the sublaminar banding, at least with taking too much cortical bone and trying to pass those bands underneath, in some ways I felt like we were weakening the trabecular architecture of the bone at the levels above and creating another problem. And I had seen a couple cases where we had either pedicle fracture or laminar fracture, but that also in some ways would be related to the amount of stress you put on those bands. But ultimately, where I see this heading in the future is, can we develop some sort of algorithm where we take into consideration things like the patient's bone mineral density and what their Hounsfield's units are like on their CT scans, their corrective goals, their age, gender, all these other things, and kind of factor that into better prescribing a material that's best suited for the patient, and how can we combine those materials to create the best biomechanically strong and biomechanically appropriate construct. So, Jeff, do you have any thoughts or questions or concerns regarding this?
I mean, great talk, Zach. Thanks for that. You and I are on the same page that we want to go from a fuse long segment, whether it be T11, 10, 9 to pelvis, to unfused and finally have some way to get a soft landing or transition there. And so you are trying to get your transition through rod materials. And I think that my way is getting transition and that soft landing through these tethers. I'm not doing the sublaminar tethers you mentioned there. So I'm doing more of the spinous process tethering, which again, just another way to skin that cat to get the soft landing.
Jeff, have you done both techniques, and how did you arrive at using the spinous process method versus the sublaminar method? Not to steal your thunder, but
yeah, no. So clinically, I only do the spinous process tethering. I played around in the lab on the sublaminar technique, which you talked about. So I think you're right that there is a significant amount of disruption in the cortical bone, trying to make your little windows to get tethered there also. And also conceptually passing something on the spinal cord itself under lamina is a risk I don't think we need to be subjecting patients to with an unproven benefit. So that's sort of why I go with the spinous process. And then additionally, the spinous process tethering offers pretty minimal disruption of the soft tissue. So if for example, I'm doing a T10 pelvis fusion, the T9 spinous process is essentially shingled over T10, so there's only minimal more soft tissue exposure to the mid spinous process of T8, as opposed to some more soft tissue disruption. Just because this is a debate, I think that my one big concern with Zach's concept of his soft landing is it's not soft enough. Obviously, there's a significant difference between a titanium rod and a tether, so the tether may not be enough, but I think the titanium is maybe a little bit too much.
And I'm going to go over some of the work that's out there on low distribution tethers, and I encourage everybody to look at the literature out there that's on these. I've been forced to be part of several studies from when I was at Virginia, and there's a lot more out there in the literature. With that, now let's look at the technique I've been using on my cases.
So in terms of my my weave technique, there's a couple different ways in the literature reported. What I typically do is start on this graph here, number 1, where I'll thread in the interspinous between T10 and T11, and then we'll go through a hole I drill and use a tenaculum at T9 spinous process, and then thread through to the T8 spinous process, then back down into the T9 spinous process where it'll be one hole, but the tether will pass through twice, and then finally loop down back through the T10, T11 interspinous space.
That's helpful to know. I mean, so when you're doing, your first pass is through the posterior ligamentous complex, not through the spinous process itself.
Yes.
Is that right? Yeah.
Yes.
Yeah. And then you pass through the spinous process. You just make a hole with your AM8s with your drill, and then just pass it through.
So I drill a little hole using the matchstick, and then there's a tenaculum you can use, and sort of that way you sort of pinch on both sides, making sure you're all the way through.
Yeah.
And then I'm not sure if it's showing on these slides. The Merceline tether has a sort of blunt needle attached to it, which makes it easier to pass through.
Yeah. Very good. Yeah, I think your point is very well taken, and that's what we're trying to figure out. Like, right, is what's the optimal degree of stiffness to maintain structural support versus, and what's not enough, that we're not creating enough tension or enough ligamentous augmentation. And so it is kind of two separate camps. The tethers being something where it's more of a ligamentous augmentation technique, and the distributed loading rod technique for me is more of a how do we? It's still about fixation. You're still getting those levels to fuse, and I'm still viewing that as part of my construct, as opposed to, that's why I refer to it as a UIV as opposed to the UIV +1 or something, where I'm putting those ending that titanium rod. So, and that's the question. I've said that a couple of times. Maybe a titanium rod is still too much, and so where do we draw that line? So are we, is there an option to start talking in the future about, bringing peak rods back, or incorporating 5/0 titanium? Because I do agree with you. I mean, the point of a single non-segmental construct involving 4 pedicle screws and 2 titanium rods is still rigidity and fusion, right? Mm-hmm. So it does have that issue with it. So, moving forward, that's what I mean. We have so many kinds of materials. It's just we haven't gotten to the point where we can use them necessarily in the way that we think they should be prescribed. So moving forward, do we look at other materials? Do we look at PEEK? Do we look at, even going down to a 5 millimeter titanium rod, things that might give that even more gradual transition. So, I just did a case yesterday where we stopped at T9. This guy, we did an L4 PSO. It started with A-lifts and laterals, and he had, I don't have the pictures here, unfortunately, but 7 degrees of lumbar kyphosis. So really as big as it gets from a corrective standpoint, stopping at T9, and we ran 5.5 cobalt up to 6.0 tie to 5.5 tie. So that's one of those cases where, depending on where we need to stop, how can we alter those materials to really be optimal? And I think that's going to be the challenge moving forward from the way I do it, is how do we answer that call to determine that optimal degree of stiffness, so we aren't still placing them at undue stress at those adjacent segments.
Your point, I don't think there's a holy grail, right? Maybe for your patient there who need a really major correction, you need to have more and go higher go to T9 with the transition rods versus a little old lady who maybe doesn't need quite as much correction. You'll need just a tether. And I think that's going to be the real thing in the future, is we look at more sort of patient-specific outcomes and how we can determine ideal optimization on patient-specific levels based on sort of large clinical outcome.
Yeah, I agree. And I think that's really what it's going to boil down to. And I think that is the biggest secret for the future in solving that problem, is going to rely on our partners here to help us do that. Is I look at all these things on a scale, right? It's all a gradation, starting from super stiff to less stiff, right? So whether you look at all these factors that we can put into our magical thought processes and say, well, yeah, this person would be ideally suited for a tether versus a PEEK rod versus a small diameter titanium rod versus a large diameter titanium rod. All those are just a gradient going from stiff to less stiff. And so I think it's not about, well, what's better, a tie or a multiple material rodded construct, as much as what's the best thing for that individual patient, and I think that's how we have to think moving forward, not making everything fit with whatever it is that we do or like best, but what's the most accurate thing for the patient.
100%. And that's going to be, we're fortunately both young in our careers. I think as the field evolves, and hopefully we're part of it, we'll get more answers like that. Yeah, I agree. I think that's where a lot of this is headed, because like you alluded to as well, I mean, we can only do so much to optimize our patients and make up for the things that have been affecting them for years, including their bone quality and obesity, as you mentioned. And so we just got to control what we can control, and being more accurate with our intraoperative techniques and our planning is probably the best thing we can do. Yeah, Reg, what are your thoughts on this debate regarding a gradient of materials here and the most accurate way to prescribe a construct for an individual patient?
Well, Zach, thank you very much, and Jeff, thank you as well. This is some really interesting work you're both doing, and let's have a few comments about that. These topics are near and dear to my heart. I've been doing this for about 25, 30 years. And we've always been concerned about types of metals and things like that. So what we're really talking about is a transition or a change in stiffness in long constructs. We're talking about a soft landing. We want a gradual change in stiffness versus an abrupt change in stiffness. And for years, we've all tried different things. At the rostral aspect, we've tried hooks, be it laminar hooks or transverse process hooks. We've placed unilateral screws, unilateral transverse process hooks. We've done polymethyl methacrylate injections to try to diminish that. Chris Shaffrey and Justin Smith, Shay Bess, and I have helped NuVasive design a tether, which Jeff talked about. We talked about the finite element analysis as well as the clinical outcomes of stiffness. We talked about rod stiffness. We talked about going from 3.5 rods to 6.5 rods. As everybody knows, as you increase the radius of a rod, you cube the strength. So to go from a 5.5 to a 6.0 rod may not sound like much, but that radius change is actually cubed. So when we talk about transitioning rod constructs, Zach brought that out. He actually warmed my heart when we had a dinner conversation, because that was talked about 9 years ago when we had the first kickoff meeting in Sundance, Utah, to design the Reline system. And we talked about if you went from the ilium up to the cervical spine, as you changed the diameter or the material on the longitudinal member, you could change the ability of the rod to transfer full forces. So what Zach talked about is exactly what Shaffrey and I and a few others talked about in the initial design features 9 years ago or so of the Reline system, which is now even being carried up to a Reline C system, which can have different sized rods and different types of rod materials. As we evolved years ago from stainless steel into titanium for MRI compatibility, we found that titanium had a spring to it. It was elastic. So what we would have to overbend a rod, and then when we put a titanium rod in, we would actually lose correction. We started using larger rods and then cobalt chrome rods, which are stiffer and also stronger. If we talk a little bit more about stiffness and strength, stiffness is an elastic feature. It's like a diving board. So if you look at titanium, if you bend titanium, it bounces back. That's an elastic component. Strength is when something bends and stays bent. So cobalt chrome is stronger, probably 30% stronger in yield strength and stiffness. But where cobalt chrome is superior is it maintains the bend. Why is this important? Because if we start looking at stiffness at the aspect of a construct, as Zach talked about, eventually there's a trade-off. Thus, in summary, what Zach's talking about are very sophisticated principles that surgeons should use up and down the spine. Even the cervical spine, do we use a 3.5 or 4.0 rod? Do we use a stainless steel or cobalt chrome? I think it's important upon all surgeons, whether we do one-level fusions or multi-level fusions, to understand how a rod's diameter and the material can change both how a surgeon corrects a deformity and if that deformity correction is maintained long-term. That's a little bit different than tethers. Tethers are really used at the rostral aspect. So Zach and Jeff talked about using interlaminar tethers. So for old guys like me, the concept of tethers aren't new. Before we had screws in the cervical spine, we used 18-gauge wire. Then we took 22-gauge wire and we braided it, which had the same strength as 18-gauge wire and was much more malleable. Then the Songer cable came around and the Atlas cable came around, and a thing called soft wire came around, which were stainless steel and later titanium cables that allowed us to do spinous process wiring or facet wiring or sublaminar wiring. So for old surgeons, the concept of a tether is a well-established concept. So about 3 or 4 years ago, Chris Shaffrey, Justin Smith, Shea Best, Frank Schwab, and Jenny LaFage and I started playing with some tethers. And we did the first early finite element analysis looking at this. We went to the lab, and now we have some clinical scenarios where we're trying to figure out what's the optimal type of tether, how rostral do you go, how much tension do you put upon that tether. I think Jeff discussed this very, very well. And again, I would like to refer you to the excellent work of Justin Smith. You can Google that and just look at his several articles. I think Justin's written about this as much as anybody. We also talked about, do you do sublaminar tethers or spinous process tethers? And if you use a spinous process tether, it preserves the muscular envelope. If you do a sublaminar tether, you're doing more deep denervation of the posterior muscles. So it seems to me that to use a matchstick and then a tenaculum at the base of the spinous process, you have to go to where the spinous process hits the lamina. If it's too high in the spinous process, it will fracture the spinous process, not unlike a clay shot-burst fracture at C7T1. So you want to use the matchstick, you want to use the tenaculum down closer to the lamina and do a weave pattern 1 and 2 levels above. You're preserving the posterior musculature. Even if you use a 3.5 titanium rod at the rostral levels, you're still having to denervate by placing screws or hooks. You're stripping muscle. You're buckling with the facet joints. I do think Zach is extremely thoughtful when he talks about changing the stiffness of the longitudinal construct. So to me, if you can combine the best of both worlds, if you would have stiffer, stronger rods where you need to correct and maintain correction of a deformity, particularly down low or in the apex of a curve or after an osteotomy, and then as you become more Ross on the spine, you can probably go to less stiff rods. And again, you can diminish that stiffness based upon diameter and material. Zach also talked about peak rods. So we've used peak rods for years, and we designed peak rods used in Europe now for lumbar areas. And the peak rods have not panned out as much as people like. So it's an interesting concept, but clinically it's just not panned out. So again, I think this discussion was simply excellent. I think pay particular attention to the technique of tethering. You can also go online and Invasive can supply you with those videos about tethering. I think we all have to do a little bit more studying to determine what is the optimal rod construct. Whether you change the longitudinal members or not, I think we're still trying to figure that out. And gentlemen, I think you've done an excellent job of this, and I'd like to congratulate you. Thank you.